Hi, Jacques.
Hi, Nicolay. How are you?
Well, thanks. How are you?
I'm well. We're all ready. I'm obviously chairing, so I will introduce and do the what do you call it, the intro slides. I'll share them from my side,
Okay, perfect.
um, and then Caroline's going to present from her computer, and then Amar's going to present from this computer. Yeah, so
Okay, awesome.
we'll manage it from this side. You don't have to worry. Yeah, so we'll start just after four, after about 40 has joined.
That's right. And I'm
Cool.
sure you're very comfortable sharing slides by now. We don't need
Hmm.
to check.
Yeah, no, I think we're fine.
Okay,
Cool.
awesome.
Thanks, Nicolay.
Sure. Cheers.
Cheers.
Am I audible?
Yes, you are.
Yes.
Great, thank you so much.
Apologies, I just wanted to change my background. Good afternoon, everyone. I just want to check, am I audible?
Yes, yeah.
Great. Welcome everyone to this Monday afternoon's deep dive from, I suspect, quite a cold and possibly clammy South Africa. I'm not sure if there's anybody who's experienced snow yet, but it seems like there are some places where there's been quite a bit of snow already. So today our topic is thrombocytopenia, something old, something new, something inherited, and something immune. I'll be chairing the session, and the presentations will be by, firstly by Dr. Caroline Steyn, and then Dr. Amar Dowd. So, as always, blood is the deep dive is brought to you by the Blood SA Foundation, South African Clinical Haematology Society, and SASHETS, and today, obviously, in collaboration with the University of the Free State. We want to thank the deep dive management team for the stellar work they're doing with this platform, and to highlight Prof. Verberg, Dr. Kritzinger, and Dr. Smith in their role in this amazing educational platform. Just some housekeeping notes. The sessions are recorded and can be found at the Blood SA website at bloodsa.org.za under Resources Deep Dive. And please, this is supposed to be an interactive session, so any questions, comments, put them in the chat box, and at the end you can also unmute and ask your question live. CPD points will be submitted to HPCSA for each registered South African attendee. You must be attending on your own Zoom link to get the CPD points and not as part of a group. You must attend for at least an hour. And yeah, you must ensure that your HPCSA registration number is entered correctly when you register for deep dive. If there's any questions, just send an email to admin@bloodsa.org.za. You can join the mailing list so that you're up to date with things that are happening, and you can join it through the website at resources, subscribe to Deep Dive, or use the QR code on the screen. And at the end of the session, there will be, when you close the session, there will be a feedback form. We value their feedback, so please take a minute to complete the feedback form. Our agenda is, Caroline will start with a talk on ITP, and there's some new things there. And then Amar will follow that with a discussion on germline mutations in thrombocytopenia and ITP. And then we'll follow with a Q&A. Most of you know Dr. Caroline Steyn by now. She's a specialist physician and clinical hematologist at our unit here, and an affiliated lecturer, closely involved in training students and registrars in internal medicine and hematopathology. She's got a keen interest in patient blood management and an integral part of the team. Dr. Dowd is currently a fellow, supernumerary fellow in clinical hematology in our unit, originally trained as a hematopathologist in Malaysia, and is from Sudan, and has joined us in 2024 as a fellow. So next week we've got a break because it's Youth Day, so happy Youth Day to everybody. And then without further ado, I'm going to hand over to you, Caroline. You can start sharing your screen. I'm going to stop my share and you can start.
All right. Thank you so much, Jack. And again, thanks for the opportunity to present to you today. It's always a privilege. So I just want to ensure that the correct slide is showing.
I think it probably just takes a
sorry.
while to load. Have you shared?
Okay.
It's coming. Just
there we go.
Yep. There we go. We
Is
can
that
see your
better?
slide. Yeah,
All
we
right,
do.
100%.
Perfect.
Thanks. All right, so I'm going to be doing a bit of a refresher, if you will, on ITP with some exciting new angles to discuss as well in terms of the pathophysiology and treatment of this disease. So I'm going to endeavor to finish in about 45 minutes, so to allow Dr. Dowd to also present. So let's get underway. Sorry, let me just advance quickly. Right. So ITP, just as a review, is, as we know, a heterogeneous rare autoimmune disorder, essentially characterized by immune-mediated platelet destruction and suppressed platelet production, resulting in isolated thrombocytopenia. And this is, in a nuts and bolts summary, really a consequence of autoantibodies targeting platelet glycoproteins. But there are many other mechanisms that have been described, and that's what I'm going to try and highlight today. It is one of the more common causes of thrombocytopenia in otherwise asymptomatic adults. Rarely a fatal disease with severe bleeding in only a small proportion of patients, but unfortunately has this unpredictable disease course, with chronicity being a major problem, particularly in adults, with significant impacts on health-related quality of life. ITP, as we know by now, replaces the terms immune thrombocytopenic purpura and idiopathic thrombocytopenic purpura, which reflects the known immune mechanism and the relative absence of purpura as the clinical presentation. And the cutoff is essentially a platelet count of below 100 without reduction in other cell lines and without other apparent causes of thrombocytopenia. So just as a very, very quick kind of history lesson, the first case of ITP, or first description, was in this early 1700s, described by Paul Verhoef, who he reported the first classical case of ITP in a teenage girl with cutaneous and overt mucosal bleeding, which followed an infectious disease, and it led to the eponym of Verhoef's disease, which was previously used to describe this entity. But basically this is an obsolete term, obviously. And then, just of interest, in 1916, a physician called Paul Kasnelson postulated that the pathophysiology of ITP is similar to that of autoimmune hemolytic anemia, and suggested that platelet destruction occurred in the spleen. And this led to the first successful splenectomy in a 36-year-old lady with a presumed chronic ITP, which improved her platelet count from 2 to 500 in a matter of days. And then finally, just in 1950, Dr. Harrington injected himself with blood from a woman with ITP. His platelet count immediately dropped, recovering a few days later. And as you can appreciate, there have been significant advances in both the understanding and the therapy of this disease in later years. So terminology-wise, just a quick revision is that primary ITP refers to isolated thrombocytopenia with no other apparent causes of thrombocytopenia, no secondary causes present. Secondary would denote all other forms except primary, and one needs to designate the presumed cause in parentheses, like SLE associated. And there are some well-described phases of ITP ranging between 3 months and a year to denote the different disease phases. Now, severe ITP has been defined as bleeding symptoms sufficient to require treatment, and this usually occurs at lower platelet counts, but I think that this isn't set in stone. So epidemiologically, this is quite an interesting concept, that the prevalence of this disease far exceeds the incidence. So about 1 to 6 out of 100,000 adults will be diagnosed with ITP in the general population. The awareness of this disease increased significantly in the 1970s, when automated platelet counts and routine full blood count testing became kind of standardized. So basically just that, detecting basically previously asymptomatic patients who now were observed to have a low platelet count, but weren't necessarily symptomatic. The prevalence in adults far exceeds that of children, bearing in mind that children sometimes will often have a self-limiting cause, often secondary to viral infections. And about a third of patients are asymptomatic. Interestingly, young females are sort of the classic example of an RTP patient, but as the population ages, the predominance swings a little bit towards the male demographic. So there are a number of diagnostic challenges. Firstly, distinguishing RTP from other causes of thrombocytopenia because of the similar clinical picture, but vastly different management of whether it's now a thrombotic microangiopathy or RTP. We can obviously appreciate that the management is going to be very different. And then determining whether the RTP is primary or secondary is sometimes more challenging than one thinks. This secondary cause is not always easily apparent at the outset. So the other issue is that there's still a lack of specific diagnostic tests. It's still essentially a diagnosis of exclusion. Antiplatelet antibodies are unfortunately not shown in about half of patients with RTP. So the sensitivity and specificity are, as we know, quite limited. Antiplatelet antibodies may be present also in other thrombocytopenic situations like thrombotic microangiopathies, although there is significant interest in using these tests more routinely. At this point, I think we still don't have consensus here. I think the other point to just make is that the causes of secondary RTP are generally quite well known, but just a reminder here of these various categories that may be involved. And obviously in our sphere, the lymphoid malignancies, infections, and autoimmune syndromes, which we may share as clinicians with, or as hematologists with our rheumatology colleagues. There's often a lot of overlap there, just to bear in mind that these are some common secondary causes. But the most compelling evidence for an RTP diagnosis is still a platelet response to RTP-specific therapy. Clinical features I'm not going to spend too much time on. We all know that the typical pattern of mucosal type bleeding or platelet type bleeding. I mean, interestingly, the rate of bleeding depends on which cohort you're looking at, because patients, the bleeding seen in specialty clinics will be higher than those identified incidentally, because these are the patients that have got symptoms and ultimately come to attention. So the rates of bleeding reported from expert clinics probably represents an overestimation of the actual bleeding risk in the general population. The greatest concern, as I said before, is a lower platelet count, but there's a poor correlation between absolute count and bleeding risk. And we always say in our unit that not all cytopenias are created equal. A patient receiving intensive chemotherapy for AML and becoming thrombocytopenic from that is far more likely to have significant bleeding than a patient with RTP. And there are various reasons for this, one of those being the production of young hemostatically active platelets in patients with RTP. This is just a very interesting survey that was done. The I-WISH survey, RTP World Impact Survey, was an exploratory cross-sectional survey which was designed to establish the multifaceted impact of RTP and its treatment on patient lives. And I just wanted to highlight this because I think we as clinicians don't always appreciate the significant impact that this disease has on the patients that we treat in terms of morbidity, not just mortality. This study basically focused on the perceptions of 1,500 patients and almost 500 physicians from 13 different countries regarding the diagnostic pathway, frequency and severity of signs and symptoms and treatment use. So one can just sort of appreciate all of the different facets that these investigators looked at. And this is quite telling for me, is that there was a big discrepancy between the patient-reported symptoms of fatigue compared to physician-reported symptoms. I think sometimes we just don't ask this to our patients. And this was quite surprising to me, is that most patients, one can see the percentages here, are all in excess of 3/4 and almost, some 84%, is 8 out of 10 patients felt that RTP had a negative impact on their energy levels, their ability to exercise, work, concentrate, and undertake daily tasks at least half of the time. So this is really, I think, a huge area of unmet need that we need to not overlook. as ITP treaters. The fatigue that patients experience is multifactorial. The contributors would be, the presence of anemia and iron deficiency from bleeding, the underlying disease itself, psychosocial factors, poor sleep, maybe anxiety about the diagnosis, the medications we give the patients, and then the fact that this is actually quite an inflammatory disease. What I found also interesting is that there are multiple support groups for patients and booklets that have been published on how to manage your fatigue in ITP. So, I mean, if you can just see the contents of this booklet that I found on the web, I mean, these are obviously frequently asked questions or at least frequently experienced symptoms. And I think that we need to just remember this when we see patients. And this ITP conference is happening next month, actually, in Philadelphia, which is a sort of a combined event between patients and healthcare providers where patient questions can be answered. And I think a lot of education, it sounds like a lot of education about the disease takes place. So that's really a lovely initiative from our colleagues overseas. So just in terms of pathogenesis, like this, if I can be facetious for a moment, the sort of student and registrar version of the understanding of ITP essentially is captured in this little cartoon where we have this perpetuating cycle of activated macrophages presenting platelet antigens to T cells with recruitment of B cells to produce antibodies against these platelet antigens, resulting in basically antibody-coated platelets being prematurely destroyed in the spleen. And to be completely honest and transparent for a minute, this is, for quite a while, this was kind of what I understood the pathogenesis of ITP to be. But that's obviously not all. The pathogenesis of this disease is actually very interesting, complex, but fascinating. The fundamental summary is still there's an increase in platelet destruction and a decrease in platelet production. So one can still not throw that out the window, that's still true. But the exact critical event leading to platelet autoimmunity actually still remains unknown, despite extensive research in this field. The crux for me is still just to realize that there is a loss of peripheral tolerance to platelet surface antigens, leading to the activation of B cells and production of autoimmune antibodies. So that is still the cornerstone, and we mustn't, be too disparaging about my previous slide. That's still really important to understand. But there are multiple other mechanisms that I'm going to quickly try and allude to now, including some of these listed here. So if we look at a closer look at some of these pathophysiological mechanisms, I'm going to try and touch on these entities. So I'd like the audience to just quickly sort of familiarize yourself with this diagram. We're going to be talking about mesenchymal stem cells at the red sort of cell at the top, and then Tregs. We're going to be talking about CXCR4, and then a little bit about mTOR signaling as well. So I'm going to take it step by step. Right, so in terms of the role of mesenchymal stem cells, we know that these cells were first identified actually from bone marrow. This population of cells is defined primarily by its ability to form colonies in tissue culture and the ability of single cells derived from these colonies to differentiate into various cells like osteoblasts, adipocytes, and chondrocytes in vivo. But the interest in mesenchymal stem cells has certainly been, I think, popularized by the potential role in kind of regenerative medicine. But in terms of ITP pathophysiology, it's been demonstrated that these stem cells modulate megakaryocyte differentiation and growth, and actually strongly contribute to the maintenance of tolerance. And this is both by stimulating T regulatory cells through interleukin-10 and suppressing pro-inflammatory cytokines like interferon gamma. The issues in ITP is that these mesenchymal stem cells exhibit a decreased rate of growth, abnormal morphology, increased tendency to early death, as well as a decrease in the production of these important anti-inflammatory cytokines. And this altogether basically compromises megakaryocyte development. It's also been demonstrated that the overexpression of microRNAs and the sort of overactive complement signaling leads to early death of these mesenchymal stem cells. And the therapeutic potential here is actually the use of one of the mechanisms of ATRA is that it downregulates these microRNAs that contribute to the signaling, as well as inhibiting complement activation, and this basically restores mesenchymal stem cell function. One of the mechanisms of ATRA, there are others that I'll also touch on. So just realizing how actually important these cells are. In terms of chemokine signaling, we know that the binding of stromal-derived factor 1, which is a chemokine, to its receptor CXCR4 is involved in many pathophysiologic and physiologic processes, including the entry of HIV into T cells, as cell migration, hematopoiesis and tissue regeneration, and cancer development. And also this signaling pathway has also been demonstrated to be involved in the maturation, proliferation, and migration of megakaryocytes. There are conflicting results depending on which studies one looks at, but the basic understanding is that altered mesenchymal stem cell mass, as we saw in the previous slide, leads to less stromal-derived factor 1 and less CXCR4 signaling. And the potential therapeutic role here is actually supplementing stromal-derived factor 1 and thrombopoietin. So yeah, there's interest in this mechanism as well. Then, in terms of defects in antigen-presenting cells, we know that dendritic cells are the most potent professional antigen-presenting cells in the innate immune system. These dendritic cells are also impaired and dysfunctional in RTP patients. Catania and his colleagues demonstrated that dendritic cells stimulate actually autoreactive T cell proliferation when they are challenged with platelet exposure in vitro. So it's also been demonstrated that dendritic cells secrete IDO1, which is indoleamine 2.3 dioxygenase, and this enzyme has also been shown. The lack of this substance impairs Treg differentiation, and I'm going to touch on Tregs in a moment as well, how important they are in this disease. Now, in terms of macrophage, the role of macrophages in RTP, we know that these are the primary phagocytic cells causing splenic platelet destruction. During inflammatory states, macrophages upregulate the MHC class II molecules and enhance their antigen-presenting capability. But this is a double-edged sword in RTP, where macrophages both destroy autoantibody opsonized platelets and additionally process and present platelet autoantigens to autoreactive T helper cells, resulting in essentially like a vicious cycle, a continuous feedback loop of antigen presentation and platelet destruction that needs essentially to be broken by immunosuppressive therapy. T cells are what I wanted to say about the role of T cells in this disease. Tregs essentially are the star of the show in terms of immune tolerance and prevention of autoimmunity in general. The more I read about Tregs, the more I thought they may be the perfect cell, but unfortunately they aren't. They also, because of their regulatory function, they may also limit some beneficial responses, like limiting anti-tumor immunity. So if you've got overactive, Treg function, this may limit tumor detection by your immune system. And we know also about the entity of adult T cell leukemia lymphoma, which is also Treg clonal proliferation of Tregs. Nevertheless, these cells play a very key role in RTP pathogenesis. Basically, they have multiple mechanisms at their disposal to mediate their suppressive effects, and they can be grouped into these 4 basic modes of action: suppression by inhibitory cytokines, suppression by cytolysis, suppression by metabolic disruption, and suppression by modulation of dendritic cell maturation or function. Now, in RTP, Tregs may be more key than previously thought in the biogenesis and persistence of this disease. In bone marrow subsets of patients, of ITP patients, it's been demonstrated that there is a tendency towards higher Th1 and Th17 subsets, which are, as we know, the pro-inflammatory response, and lower subsets of Tregs have been demonstrated also in the bone marrow of patients with ITP. So this results in this overall pro-inflammatory state with reduced self-tolerance. The CXCR4 pathway, as previously mentioned, may also be implicated in Treg function. Modulation of this axis may have treatment implications, as shown in the cartoon on the right-hand side. And the interesting phenomenon is that patients responding to immunosuppression or monoclonal antibodies and TPO receptor agonists, Ritux, romiplastim, and eltrombopag, has the part of the reason that these drugs are effective is that they increase platelet mass and thereby stabilize Treg function. So yeah, it's just a little bit of an interesting concept that the increase in platelet mass caused by these drugs stabilizes Tregs and thereby contributes to responses seen from these agents. Autophagy is an important process as well in the bone marrow and obviously in other cells as well. This is the process where abnormal, malformed proteins and damaged organelles are eliminated, and this is a very crucial process for homeostasis of cells and growth. There have been studies showing that the knockout of autophagic genes in ITP actually prevents appropriate megakaryopoiesis. Part of this is because of increased mTOR expression, which inhibits autophagy and leads to abnormal platelet function. And interestingly, enhancing autophagy alleviates apoptosis and improves platelet viability by converting Th17 into Tregs and stabilizing them. And some of the drugs that can be used as autophagy modulators are, again, our good old faithful ATRA and mTOR inhibitors like sirolimus. So just as a summary of these processes that I've spoken about, in patients with chronic ITP, bone marrow examination with molecular techniques could demonstrate an increased pro-inflammatory state, alterations in megakaryocyte development, and stromal factor 1 CXCR4 axis signaling, defective mesenchymal stem cells, and dysfunctional Tregs. In this manner, treatment at different levels may improve this bone marrow microenvironment and correct megakaryopoiesis, as shown in this figure. So we've discussed now the potential role of ATRA in inhibiting mesenchymal stem cell apoptosis, but other mechanisms attributed to ATRA involve, as we've also now seen, stabilization of Tregs, and ATRA's capacity of inducing autophagy, which can further explain its protective effect. So yeah, it's just really fascinating to me how ATRA works in this disease. This agent has been used in various clinical settings with with response rates of up to 50%. There was another phase 2 study which randomized almost 100 patients to ATRA plus danazol versus danazol alone for 16 weeks, and a sustained response was observed in 2/3 of patients using ATRA and danazol versus 25% using danazol alone. And since mesenchymal stem cells are now defective in this entity, the theory that you can replace mesenchymal stem cells via intravenous infusion was also explored. 2 studies have assessed this potential therapeutic intervention, which showed quite interesting results, actually. I don't unfortunately have the numbers of patients in these studies, but the claim was that there was a complete response in 75% of patients at 12 months and 100% at 24 months without the use of any other immunosuppressive agents. So, you know, I'm not aware of any of people actually using mesenchymal stem cell infusion to treat ITP, but the theory is there at least. So more on treatment in a few minutes. So just what are some of the factors that alter the disease course in ITP and affect the severity, chronicity, and response to therapy? This is just a quick table demonstrating some of the bone marrow-related factors we've discussed, as well as some other important items like sociodemographic factors, clinical presentation. Interestingly, a higher platelet count at baseline actually confers risk for chronicity, as well as the presence of antiplatelet antibodies if one detects them, and these other autoimmune markers like ANA, antithyroid peroxidase antibodies, as well as previous treatment-related factors, like if a patient has required treatment with polygam and methylpred in the past, or other immunosuppression, then this does also predict for chronicity. So these are just some interesting factors to remember. In terms of clinical presentation, things like no recent viral infection history, it makes sense intuitively. If you've had a viral infection and your platelets have dropped, then there's probably a higher chance that they will recover spontaneously. What about sex hormones? So is this a problem of too much estrogen or too little androgens? So the potential role of female sex hormones is supported historically by high incidence of autoimmune diseases in women. There have been demonstrated to be estrogen receptors on platelets and megakaryocytes, so perhaps this is the role of estrogen in this disease. But this is really quite conflicting. Again, the equivocal, it's quite equivocal depending on which source you read. Interestingly, females also tend towards Th1 immune responses. In terms of what is probably happening is that females have too little androgen, actually, rather than too much estrogen. So androgens have been shown to upregulate interleukin 10, which is the one that we want, and stabilize Treg function. So the lack of androgens actually may contribute to chronicity in women. Males apparently tend towards a Th2 immune response, which I didn't know before reading this article. And androgen-induced immunosuppression may help maintain peripheral tolerance. This is where our other old friend danazol comes into the picture. What about antibodies? Patients with ITP have a high prevalence of autoimmune markers like ANA, antithyroid peroxidase, lupus anticoagulants than the general population. About a third of patients, or a fifth to a third of patients with ITP will have a positive ANA, which interestingly does also predict for a poor response to initial steroid therapy and a tendency towards chronic course in this disease. But it does also predict for better responses to rituximab. Should we test? So we always sort of wonder, should we do an ANA in a patient now diagnosed with ITP? Should we go ahead and just do an ANA, even if the patient doesn't have any signs of another underlying autoimmune disease? The 2019 sort of international guidelines say yes. Recent American guidelines say no, not systematic testing, only if there are clinical features of autoimmunity underlying, or as you're suspecting that this is secondary ITP. I'd welcome any comments at the end. I think we do tend to test for this. And I think obviously one interprets the titer of the ANA and the pattern of the ANA, whether it's a speckled or homogeneous pattern. What about antiplatelet antibodies? It seems that the jury is still out. Antiplatelet antibody specificity is quite interesting. Anti-glycoprotein 1b9 antibodies predict for a lower response to steroids and polygam, whereas I think I need to end? So no, okay. Anti-glycoprotein 2b3a antibodies predict for a better response to these agents. And there is a proposed mechanism here. And this is potentially where the role for sialidase inhibition with oseltamivir is coming to the fore. And this is obviously just very interesting given that, there's a lot of... Oh no.
Are you still on?
Am I on?
Just check if you're still audible.
Sorry, apologies. It seems like I may not be audible. Can anyone still hear me? Or not hear me?
Yes, we can
We
hear
can
you.
hear you.
Oh, wonderful. Thanks. Okay, now okay. My apologies. All right. So oseltamivir is a potential therapeutic intervention that one can consider in a patient with refractory ITP because of this role for inhibiting sialidase and thereby, prolonging the lifespan of platelets by preventing their removal by the Ashwell-Morel receptors in the liver. So just quickly on management, I'm going to try and go over this really fast. I apologize. I just think I'd like to get to the more interesting things or the more novel things. So just we are going to touch on this though. The management pillars are essentially we need to know when do we treat these patients, where do we treat them, in or outpatient, and how do we treat them. So this is still kind of the landmark I think guideline is the American Society of Haematology guideline on ITP that was revised in 2022. This is just a quick diagram about if you have a patient with bleeding. So this is now not a coincidental finding or someone that has had an incidentally detected low platelet count. This is a patient now presenting with bleeding. One needs to obviously do a rapid clinical assessment and decide whether this bleeding is critical, severe, or minor. And these are the options used to treat, which I'm not going to spend time on. In terms of to treat or not to treat, the ASH guideline still clearly says that patients with a platelet count of above 30 and either asymptomatic or only minor bleeding can still be managed with observation. But I think particularly in a South African setting where patients live very far from hospital or may have other social reasons for not being able to come back quickly, I think one should just take this into consideration that we don't always have a nice platelet trajectory at first contact with the patient. So we can't tell whether the platelets were, 50 a week ago and are now 30, and that should probably be, managed more expectantly. But if one can manage a patient with regular follow-up, then one can certainly still do this type of approach. And then just whether one needs to admit a patient or not. If you have a newly diagnosed patient with a platelet count of less than 20, you should admit the patient because of the concern that a patient will need rapid review and obviously to exclude other reasons for thrombocytopenia. First-line therapy for adults is still corticosteroids. I'm going to go on. Second-line therapies, apart from the major three that we all know, the thrombopoietin receptor agonists, Ritux, and splenectomy, the ASH guideline has now added fostamatinib, the spleen tyrosine kinase inhibitor, as an acceptable second-line therapy, so one can just be aware of that. In terms of treatment, this is just a flow diagram that is quite useful in my mind, delineating where a patient with an ITP diagnosis of more than 3 months, dependent on or unresponsive to corticosteroids. So we now need to look at second-line therapies. We essentially assess the duration of the ITP, whether it's between less than a year or more than a year, and then the distinction here comes in is that obviously splenectomy can be considered for patients who have an ITP diagnosis that's lasted for more than a year. We don't typically splenectomize patients under a year. And then what I think is very important to realize is that we need to quite early on assess patient values and preferences, because for example, if we look at the right-hand side of the diagram, if a patient places a high value on achieving a durable response, then we would be looking at splenectomy or TPO receptor agonist. And this now, if a patient prefers to avoid surgery, we'd have to go for a TPO receptor agonist if cost is not an obstacle. Whereas if a patient places a high value on avoiding medication, then one would go for splenectomy and so forth. So I'm not going to read through the table just for time's sake. This is essentially the same concept. So these are the proposed agents in chronic refractory ITP. We've spoken about ATRA and basically all of these entities. I'm going to talk about neonatal FC receptor inhibition in a moment. Options in resource-limited settings, just to again let us all realize that we tend to use the group of other therapies or kind of third-line agents earlier on because of various challenges accessing second-line agents. And also, so that is just where we do commonly use other immunosuppressive agents earlier on, like Imuran and danazol, potentially MMF as well. Right, so now I just want to get to the exciting part. This is an article that was published in 2024 but basically it's a current update on clinical trials and ITP. So this is a summary of agents not currently approved for ITP therapy, but are basically in clinical trials in various phases between, phase 1 and completing of phase 3. So this is really kind of where ITP therapy will potentially be going in years to come. So just to note that, as I said before, fostamatinib has already received regulatory approval in 2018 for refractory ITP. So that's no longer really experimental. That's an established treatment. So in terms of future directions, despite TPO receptor agonists changing and completely revolutionizing aspects of ITP, there are still lots of areas of unmet need. There have been very few advancements in treatment over the last few decades. And just, I need to highlight this. There's been a shift away from wanting to put patients on indefinite therapy or needing to put them on indefinite therapy towards trying to modify the disease course early on. So this is quite a mind shift in terms of what we're trying to achieve. And I think realizing, as we said earlier, what the severe impact is on patients with chronic ITP. I mean, wouldn't it be amazing if we can modify this disease early on and prevent a lot more adult patients becoming chronic ITP sufferers? Right, so let's quickly go to these new agents. So the neonatal FC receptor is an immunoglobulin receptor which prolongs the half-life of circulating IgG. I mean, this for me is such a neat mechanism. So basically, we know that IgG is ingested by pinocytosis, so pinocytic vesicles fuse with endosomes in which the neonatal FC receptor can bind IgG. So excess unbound IgG and other proteins into the lysosome are now degraded. So however, if the IgG is bound to this neonatal FC receptor, it's protected from degradation, retained, and then re-released by exocytosis. So it essentially protects these proteins from degradation. If we want to prevent this from happening, in the sense that these pathological IgG autoantibodies that are involved, that are coating our platelets and making them become destroyed early in the spleen, the pathological IgG also relies on this neonatal FC receptor for recycling. So if you can block this mechanism, then you can essentially prevent the recycling of pathological autoantibodies. So they do not, the neonatal FC receptor antagonists don't really remove the autoantibody, obviously, but they may give sustained reductions in serum concentration of these antibodies. There is a concern for infections, it sort of goes without saying. And the drug involved here is called efgartigimod alpha. It's a first-in-class approved so far only for myasthenia gravis, but may have, there's this trial, Advance IV, which is a phase 2 trial of IV efgartigimod in 38 adults with ITP, mostly long-standing with poor responses to prior therapy. The results of this trial were that efgartigimod significantly improved platelet counts, decreased bleeding events, and reduced plasma IgG levels with a favorable safety profile. So one can appreciate the differences here in platelet increments and a placebo versus the investigational drug. So this is really quite an exciting thought. Now, BTK inhibitors, especially ibrutinib, as we all know, have revolutionized the management of B-cell malignancies over the past 10 years or longer. Now, there's been an interest in investigating BTK inhibitors in autoimmune diseases. So Bruton's tyrosine kinase has a crucial role in B-cell maturation, antibody production, and macrophage Fc gamma mediated signaling. The issue also, as well established, is that ibrutinib is a non-selective kinase inhibitor. It inhibits more than 20 kinases by more than 90%, including important ones in platelet function, thereby resulting in a side effect of inhibition of platelet aggregation and adhesion, which is clearly not what we want in ITP. This is just very quickly, really interesting thought is that you can use low-dose BTK inhibitors as an aspirin of tomorrow because of this platelet inhibition. I thought that was really interesting. So we need inhibitors, though, with a greater specificity that obviously don't affect platelet function, because that would be counterintuitive. So rilzabrutinib is a highly selective BTK inhibitor, and this has been shown to, there was a 24-week dose-finding phase 1/2 study of rilzabrutinib in patients with ITP showed a 40% platelet response from baseline without rescue medication and a well-tolerated safety profile. So the LUNA-3 study will further investigate this agent's safety and efficacy in adults and adolescents with the primary goal of addressing a major objective in treating these patients is durability of platelet response, I beg your pardon. So this is the summary of the LUNA-3 study. Essentially, they will be enrolling 100, almost 200 adults, or they have enrolled, I beg your pardon, and adolescents with a 2-to-1 randomization and the option of non-responders being able to join the open label period after week 12. So I'm going to try and finish up now, but just one or two more slides. B-cell activating pathway inhibitors are another investigational mechanism in ITP. So there are certain signaling pathways that are really critical to B-cell activation and survival. These cytokines, BAFF, known as B-cell activating factor, and APRIL, which stands for a proliferation-inducing ligand, as well as TACI, are essentially cytokines that are involved in, as I said, B-cell survival, plasma cell survival, and T-cell independent responses and isotype switching. So if we are concerned about autoantibody production in this disease, then if you can essentially block this, then you may also induce therapeutic effect. So these drugs, ianalumab, sorry, I couldn't even pronounce that myself, from Novartis is an anti-BAFF receptor, and povetacicept from Alpine Immune Sciences is a dual inhibitor of both of these cytokines. So they may neutralize these cytokine signaling and thereby reduce pathogenic antibody-forming B cells. So this is really just very, very interesting as well. There's even a role possibly for daro. So we know that daratumumab has been used in plasma cell neoplasms for many years. There's an ongoing DART study, which is a phase 2 safety efficacy evaluation in patients beyond second-line therapy. And there are even other anti-CD38 molecules being investigated for the purposes of targeting long-lived plasma cells that are not addressed by agents targeting B cells alone. My almost last slide is that novel spleen tyrosine kinase inhibitors. There are some novel ones in development, so we know already about fostamatinib, but there are 2 new ones in development, sovleplenib and cevidoplenib, which are still, the recent randomized trials just been completed. And with sovleplenib, in relapse or refractory ITP, there have been at least 50% response rates compared to 9% in the placebo arm. So it sounds very promising. And then lastly, complement inhibition may be an untapped therapeutic modality in ITP with sutimlimab as an anti-C1 antibody already approved for cold agglutinin disease, may be actually useful as rescue therapy because these drugs have been shown to rapidly improve platelet counts within hours. Let me just go one ahead. So the take-home message is that ITP is a rare disease, but still one of the most common causes of thrombocytopenia and otherwise asymptomatic adults. We've touched a bit on these newer pathophysiological mechanisms. Initial approach, I think the take-home on the ground is that we still need to try and make sure there isn't another more serious cause of thrombocytopenia and try to exclude underlying diseases. Treatment is individualized, and just this take-home thought is that the focus is shifting towards early modification of the disease course to prevent chronicity. Thank you very much. I'm going to end there.
Thank you, Caroline. I think that was brilliant. I'm going to, for the interest of time, so I'm just moving the screens around here a bit. Just share Amar's talk. And we're going to jump in right into his talk, and then after that, I'll take some questions. Amar, over to you.
Thank you, Caroline. Thank you, Prof. Malarba. I'm just going to start my talk with ITP-PM autoimmune, which will start my talk by a case series of 5 related probands in a hematology clinic in Poland from their age ranging from 13 to 58 years of age. They are presenting with chronic thrombocytopenia. In-depth investigation and history taking, they found that they revealed that 16 cases from the families, they have a lifelong thrombocytopenia within the 4 generations. And the clinical characteristic of those patients, of the probands, they have a history of bleeding, indicating in a form of bruises, epistaxis, hypermenorrhea, petechias, and preoperative bleeding, and some of them, they have postoperative hemorrhage and subcutaneous purpura. If we see these family probands, we tend to find that they include all age groups. They are mainly adults, they are both male and females, and they tend to have thrombocytopenia from pairs up to 35 years, the start of thrombocytopenia. When the spleen size is almost homogeneous parenchyma with ranging from 3.5 to 3.8 centimeter. Further testing for this family revealed that there is no evidence of infections, there is no evidence of hemolysis, all other tests were normal. Bone marrow was done for the 5 cases, and it reveals that is normal bone marrow aspirate, with the exception of the band 3.9 and 3.2, where they found that there is the megakaryocyte, there is hypoplastic marrow, mildly hypoplastic marrow with megakaryopoiesis. So what they found also within the result, if you can see here, this band 4, which showing normal coagulation study, as well as a normal MCVs and MBV for their platelets count, and they tend to have different presentations, both 3 and 9, 2 and 9, they tend to have Down syndromes. They diagnose later on as Down syndrome after they doing further studies. So what are the studies that is not done is the cytogenetic study. They found that these patients usually have, based on the inherited thrombocytopenia that predisposed to other diseases, ranging from 45 to 50%. So they think of doing the molecular and genetic study, doing FISH for MUCOM, MBL, RANX, and ATV plus GATA, because 30% of newborns with Down syndrome, they tend to have GATA positive. So they do this test, and they reveal that those who have probands 3.9 and 4.9, they have Down syndrome, and they present usually with severe hemorrhage that needs a blood transfusion. An individual with band 3.9, they underwent glucocorticoids treatments as well as splenic embolization, because they are treated as chronic ITP, but there is no therapeutic success. So the rest of the patients or the family have undergone all genetic mutation study, and all of them, they tend to have different types of genetic mutations. So what message we take from here is that the personal detailed personal and family history is very important when we are suspecting inherited thrombocytopenia, and a bleeding history, including bleeding assessment tools, is crucial in these cases of inherited thrombocytopenia, as well as investigation using smear is for evaluation, and bone marrow aspirate and trephine biopsy are recommended. Genetic study should be upfront when we are suspecting inherited thrombocytopenia. From this home message, I'm going to base my talk today, which usually, in order to be more familiar with the various presentation of different types of inherited thrombocytopenia and primary immunodeficiencies related to thrombocytopenia, and to avoid to misdiagnose inherited thrombocytopenia with immune thrombocytopenia, as well to emphasize, to recognize and investigate the forms that predispose to other disease, and to work. Also, I'm going to talk about the workup of chronic ITP using a cytogenetic study. And at the end, few points about the treatment strategies. So what is inherited thrombocytopenia? Is a heterogeneous group of disorder. It's not like, which is different from the other hereditary problem like hemophilias and so on. It is very heterogeneous and is very rare, leading to bleeding disorder, and usually characterized by low platelets, which is less than 150, with or without platelet functional defects. Here is very important because, as Dr. Caroline just mentioned, that ITP tend to present with thrombocytopenia or platelets less than 100,000. Here we may suspect IT or inherited thrombocytopenia from 100 to 150 in some of the cases where they tend to present with mild thrombocytopenia. As well, one of the features of inherited thrombocytopenia is often manifested by mucocutaneous bleeding with different or variable severity from mild to very severe form. And there is a large heterogeneous molecular and genetic defects, some of them not yet identified. And it needs a very complex workup, including genetics, and it affects both age groups, so it can have both autosomal dominant, autosomal recessive, and X-linked as well. And 40% of important that 40% of inherited thrombocytopenia is misdiagnosed as chronic ITP, and 10% of them they present with cytopenias, other cytopenias. This graph is just to tell about is a study done for 125,000, nearly 126,000 exomes from the general population for loss of function of platelets associated genes, and they found that the prevalence of inherited thrombocytopenia among the general population is 0.39, which is 300,000. So what is the pathogenesis of inherited thrombocytopenia? As we know that the megakaryopoiesis is start from the hematopoietic stem cells, and then they tend to mature to produce or to release these platelets. So all these steps is regulated by genes, starting from transcription genes or splicing genes, and signaling as well as receptor genes, cytoskeletal genes, which is usually tend to affect the formation of the platelets and the function. And we have ion channels gene as well as metabolism and mitochondrial genes. There is genes which is others not yet identified, and these genes will tell us the early genes which affects the transcription, drives the transcription factors for the proliferations and maturation of platelets. These genes and the splicing genes plus the signaling genes, those usually when they are defective, we tend to have a platelets reduce in number, but with preservation of the function. But when we go further to find those who affect the cytoskeletal or the metabolism and the mitochondrial genes, then we have the functional defect plus the as well number defects. So we have post thrombocytopenia with defect in the function. And this is very important for the presentation of the patient because some of them may present with only bleeding, and this bleeding usually tend to be stable when it is just due to decrease in the platelets. When it is associated with decrease in platelets plus functional defects, then the bleeding will be severe and is which necessitate usually management, early management. Where is the origin of this gene? This gene originated, this diagram just represents the genes that blamed in inherited thrombocytopenia. And these are 4 tracks. The first tracks, which is the track of the where we tend to find the chromosomes, and the blue here is the centromeres. And this is all chromosomes. If you can see, all of them are affected except chromosome 2 and Y and 4 and 6. But the rest of the chromosomes are affected, where we tend to find these genes, some in the blue and some in the red. The red genes are the genes which usually detected by high throughput genetic test, while the rest, the blue genes, this is the genes which is detected early on. And when we see here also, we tend to find the year of the discovery of the genes as well in the first track or in the second track. In the third track, we tend to find at the 12 o'clock where there is the codes or the code for the proteins that is involved, and the fourth track where we tend to find the variability of the genes as well. So this gene is expressed with different expressions intensity, and the commonly in they are expressed in all the megakaryocytes, all the hematopoietic stem cell, hematopoietic cells, and the granulocyte, the megakaryocyte, the erythroids, and the common progenitors cells. And they are expressed, if you see here with in the red color, those are the genes which is highly expressed. The TPO and MBL signaling genes are highly expressed, followed by the transcription and regulation genes, and then the granules, biosynthesis, and trafficking, or the cytoskeletal genes. So these genes are present in a high number, and this slide we just show the percentage of the genes occurrence, which is usually tend to be dominated by MYH9 related genes, which is responsible for thrombocytopenia and affecting the cytoskeletons, as we come to see, and followed by Bernal Solier genes, which is 30%, and then the NKRD26 related thrombocytopenia gene and the actin genes. The rest of the genes are distributed with less number. This study is done for, yes, it's a population-based cohort study done in children and adolescents to see the time from the diagnosis or from the discovery of of the first contact of thrombocytopenia until the appearance of the disease. So this usually tend to be around 14 years, ranging from bears up to 14 years of age, and then they discover that these patients is having thrombocytopenia. What is the classification of there is different classification for thrombocytopenia, inherited thrombocytopenia, some of them based on the laboratory, and some of them based on the clinical presentations. So I'm going to start with the clinical presentation. We have patients, they present only with thrombocytopenia, and some will have syndromic forms, and others will have predisposition to additional disorder. Those who have only thrombocytopenia, there are 20 disorders from 19 genes, and usually they tend to have a bleeding which correlates with thrombocytopenia, and there is no functional defects. As we see, the functional defects tends to occur usually towards the cytoskeletals and the release of the platelets. And usually, one of the interesting things is that the reduced platelets remain stable throughout life. And usually is monoallelic variants, which usually indicate a germ cell backgrounds. And commonly we tend to find them in thrombopoietin, glycoprotein B, and glycoprotein BA, and cyclic and top genes. This is just a cartoon for the syndromic and the non-syndromic forms. We see that when some of them they present with small platelets are non-syndromic, and some of them they are syndromic and they affect other organs. They come with severe, like Westcott-Aldrich, where there is a severe infection and eczema, and there is an ion sensors where they present with myopathies, and there is others which are affecting the skins and the nuclear RNA nuclear genes. When it comes to those who are predisposed to other diseases like leukemia, we tend to find the RANX1 genes, which usually having a myeloid malignancy, and ETV6, where there is more lymphoid malignancy, and NCARD 26, where there is a myeloid malignancy. As well, some of them, they have skeletal defects like Hox and Mucium, where there is a radioulnar syntosis with bone marrow failure for Mucium or EV11, and there is absent radii for years. The syndromic form comprise around 17 forms caused by 15 genes, and usually tend to occur in early childhood. And they are involving different organs. Example of them like thrombocytopenia with absent radii or Jacobson syndromes. The driving mutation for them is CDC42, ACTB, and ARBC1B. The third form, or the third class of inherited thrombocytopenia, are those who are predisposition to additional disorder. And these they represent around 11 forms, which are separated into hematological malignancy or non-hematological problems. Within the hematological, we have usually malignancies. They present usually with isolated thrombocytopenia, and like example of them, like familial platelet disorder, which represent about 45% of the cases of the predisposition to additional disorder. And usually they can affect the myeloid, the T, B, and lymphoproliferative disorders. And the average age of presentation is 33 years. While the ATV is representing around 30%, and they can present with ALL in 19% of cases, and multiple myeloma as well as myeloid. Also, the early description of it is acute lymphoblastic leukemia. And the median age of presentation is 45 years of age. ANKRD 26 related thrombocytopenia represent around 8.4%, and there is a study of 222 patients where they found that the AML increased by 24 folds, as well as MDS and 21 folds for chronic myeloid leukemia. And the age of the presentation is again 45 years. ANKRD 26 is commonly mistaken for MDS, so especially when you do a bone marrow aspirate and refine biopsy. The other hematological related predispositions, some of them they can present with aplasia, like megakaryocytic thrombocytopenia, or which is usually caused by MBL or TAPO genes, as well as REST and mucium gene. The non-hematological forms are MYH, which is commonest, MYH9 or MYH10, and they represent around 25% of inherited thrombocytopenia, and 61% of cases are mistaken for ITP, this MYH. And 30% is undue ITP, and 12% of patients, they usually tend to have splenectomy with no success, and they usually tend to present with low platelets in the adulthood. And they can be associated with other problems because of the deposition of these dysfunctional NMIA, which is the non-muscle myosins. They deposit it in the nephrons and in the eye, as well as the liver, leading to nephropathy, cataract, and liver dysfunction. There is 225 patients with, when they did the study, they found that 55 patients, they have genotype-phenotype correlation with the thrombocytopenia. As I said, other way of classification of inherited thrombocytopenia, usually they can present clinically as well as based on the platelet size. There is genes which is commonly associated with a small platelet size, like Westcott-Eldridge, and genes usually associated with large platelet size, like MYH, as we said now, and ABCG5 and 8, and the MYH9 and SRC, those are the commonest. And there is genes which have normal size platelets and leading to thrombocytopenia as well, like ATV and KERDA 26. Those are usually associated with predisposition to other hematological or problems. There is other classification based on the other myeloid problems, as we said. Those with ATV, NKRD, and RANX, they tend to have myeloid malignancies. And this with anemias, those with RANX and MBL and GATA, especially GATA1, then they can present with anemia as well as thrombocytopenia. And these are the cases of thrombocytopenia. Again, some might present, as we said, with hearing loss. Some was present with non-hematological disorder like immunodeficiency or disorder of skeletal system. Okay, so what is the approach based on the theoretical background? We tend to find that there is usually tend to occur in a family as well as a history of bleeding, but there is some, when it comes to practice, we tend to find that even the family history might not be conclusive because some of them, they have low penetrance of the genetic penetrance, and some of them, they have percentage of de novo mutations. So we need to dig on the family history in depth in order to get if the patient is really having family history correlation with his, like the case series that we have 4 generations that have the same problems. And the history of bleeding, usually the history of bleeding is sometimes, or in majority of cases, they tend to present with asymptomatic, there is no bleeding tendency, and although their counts just start to drop in the adulthood, or they have low platelet counts from the early newborn period, but they is not having any clinical manifestation of bleeding. So, and then the presence of other additional defects, yes, there is a percentage of thrombocytopenia without other additional chronic additional defects or additional manifestation, or the additional manifestation may appear later. At the dysmorphism of the platelets and large platelets or dysplastic platelets, we still need to put an eye on the peripheral smear, because this may help in differentiating those with different insides. So what is important is that the percentage of patients with inherited thrombocytopenia diagnosed with ITP is very high, and it reached up to 40% with differences, 35% in MYH, 38% in NKRD26, and 62% in Bernard Solier, and 31% in the those patients. So practical approach, how to, what are the features that differentiate inherited thrombocytopenia from immune thrombocytopenia? And the first is the history of bleeding. And here we can use the bleeding assessment tool, as we said, although it is validated for von Willebrand's and for low bleeding tendency, but still can be used, especially for, is validated recently for dysfunctional platelets, inherited thrombocytopenia, not the inherited thrombocytopenia without dysfunctional platelets. So the onset of bleeding usually will be recent for ITP. It will be lifelong for inherited thrombocytopenia, and the change in the general health, usually there is no change in the general health for inherited thrombocytopenia, but there may be a change in ITP. There is excessive bleeding during minor trauma and menses and surgery. Usually this is tend to occur in inherited thrombocytopenia rather than the immune thrombocytopenia. And the family history usually of concern in patients with inherited thrombocytopenia, and is no family history sometimes, most of the time in patient with ITP. And at the normal platelets count, yes. Have there been normal platelets counts? Yes. In ITP, yes, there is a normal platelet counts, but in most of the inherited thrombocytopenia, there will never be a normal platelet count. All the platelet counts will be normal at one time, and then they decrease when they are subjected to stress or other. So, like what is happening von Willebrand. What has been your response to steroids? Usually in 80% of patients with ITP, they respond to steroids. There is a variable response to steroid inherited thrombocytopenia, but even those they respond, they relapse later on. Respond to platelet transfusion, usually they have a poor response, as we know, and is a short-lived response for ITP, while it is good increments and normal survival for the inherited thrombocytopenia. This is just this is from updates. It's telling us how to evaluate a possible or suspected inherited thrombocytopenia. Yes, when you suspect inherited thrombocytopenia, you start with the initial evaluation by the family history, by bleeding history, by medication history, as well as absence of any hypermobility. And then you tend to find when there is a family history, yes, there is no family history, then you go to obtain the laboratory testing and to find any abnormality. If there is no abnormality, you tend to find you do an aggregometer. While when the familial history is there, or the family history is there, then we do a bleeding score. And if the bleeding score is more than 4, then we do a baseline test to narrow our differentials. And if we see here in most of the tests that we do genetic, but it is at the bottom here. Although nowadays, as we will see, these genetic tests should be upfront in order to reduce the testing and to appropriately treating our patients. And this will lead us to what is the role of the genetic testing in the workup of chronic immune thrombocytopenia. And this is a study which is done in a single center, which is responsible for treating chronic ITP or ITP, immune thrombocytopenia. They recruit around 80 patients with both children, 26 of them is children, and the rest is adult. And they do a test for them using TG test, which is a thrombogenomic test for 72 of them. And some of them we do whole genome sequencing, and the result is segregated into those who have bleeding and platelet disorder genes, which represent 72, and those who have genes responsible for inherited thrombocytopenia but associated with primary immunodeficiency. And this we do both whole genome sequencing and the gene of rare immune disorder. So what is the result? The result is that there is patients who have from bleeding and platelet disorder. 4 of the patients, they have pathogenic mutations, and 3 of them, they have a likely pathogenic mutations. And those are the pathogenic mutations that is found. Usually, all of them is monoallelic variants. And here, I just want to highlight the high number of variant of uncertain clinical significance, and those are high. This may cause problems when we testing patients with for high throughput sequencing and find this result, because we cannot tell them about this result until we confirm the pathogenicity of the results. And again, those with primary immunodeficiency genes, they are two of them. One of them is pathogenic and usually is bioallelic variants, and one of them is likely pathogenic, which is a monoallelic one. And again, if you see here, we see the number of variant of uncertain significance is very high, which needs further workup in order to tell the patient if he is having a pathogenic variant or not. Yes, and yes. So also here, when we do this test, they found that those patients who have a complete response, they have a less variance in comparison to other patients, and those patients who have a mixed ethnic groups, they tend to have less variance. And for the variant of uncertain significance, then we think that those variants usually tend to have high number of variants of uncertain significance usually tend to be found in patients with primary immunodeficiency rather than the bleeding and platelet disorder gene. For the reproducibility of the result, they also test this result from a replication cohort. And if we see here, we find that this is reproducible results. Again, those 4 genes or the genes that is detected, the 46 genes which is detected is retested again with thrombogenomic test and with gene of rare immune deficiency. And they found that these are 12 of them, they are monoallelic and there is no biallelic one. And among the 4 biallelic, usually they tend to find 4 are pathogenic and 3 are least pathogenic. And all the pathogenics are according to ACMG variant classifications. Here, this slide just about the cases that they found them. If you can see here, they are present at different ages, starting from 1 year up to 62 years. And usually 2 of them, they have a family history, and of interest, these 2 family history, one in child and one in adults. And usually they represent all the ethnic groups, and they present with platelets from severe thrombocytopenia to moderate thrombocytopenia. And the treatment of interest here also is the treatment. Some of them, they respond to thrombopoietin receptor agonist, and 2 of them, they respond to thrombopoietin receptor agonist, and some of them, they respond minor response to steroids, which then they relapse again. This is the pathogenic variants, which is usually which is highlighted in red. So when do we consider to do a genetic testing? Yes, we consider to do a genetic testing when we have a consideration for ITP that is refractory to immunosuppressive therapy, when we want to evaluate for primary immunodeficiency, and when we want to evaluate for inherited thrombocytopenia with prior low platelets counts, with moderate thrombocytopenia, with the family history of thrombocytopenia, and those with the family history of leukemia or MDS, and when we have morphological features of abnormal morphological pictures. So these NGS have strengths, and there is limitation, the strengths, because now there is many panels of NGS, so in the cost and time, and then they allow detection of unexpected variants, and the limitations that there is a variance of uncertain significance which require further studies, and there is an ethical point concerning those are leukemic or carrier, and the lack of structural detection. The treatment is either a supportive treatment or platelet transfusion, and usually should be an HLA match to avoid the alloimmunization and the refractoriness of the platelets. TPO have a role in certain types of inherited thrombocytopenia, as well as hematopoietic stem cell transplant. Not to forget, those who are having a hematological or suspicious of hematological malignancies, they need counseling, they need a monitor every 6 to 12 months at least. And in case they have leukemia, they need a stem cell transplant. Those who have a predisposition to other non-hematological disorders, they need to consider treating the cataract because some of them may present early with this with nephropathy or cataract or hearing defects. So what is the future perspective? There should be an efforts should be focused on integrating the genomic data with the functional study to better understand the molecular mechanism. And there should be a better understanding of the regulatory role of DNA elements and the untranslated region. And there should be a focus on the epigenomic profiling, and new cases of inherited thrombocytopenia remain without diagnosis because of that. What is my take-home message is, in clinical practice, we need to recognize the lifelong thrombocytopenia not attributed to other cause, which will be a sufficient cause to investigate for genetic origin. Isolated thrombocytopenia, often misdiagnosed as ITP, leading to inappropriate management, and genetic counseling before testing is very crucial, and variants of uncertain significance require further testing. This is my references, and thank you so much.
Thank you, Amar. I think that was a excellent overview of quite a, I think, a challenging topic for many of us, and also often due to the challenge of not necessarily having access to testing. We're a little bit over time, so I just want to finish off with some closing remarks. There's been quite a lively discussion in the chat group, which we have tried to answer. Maybe just the first point is that question about testing, routine testing of H. pylori, and I think one can read there, but the bottom line is, if available, probably a good idea to treat. Reboni asked about the if metformin, which is an mTOR inhibitor, may assist, and there has actually been a trial on that, showing possibly some better sustained responses in the metformin group. And then I think maybe just why we wanted to highlight the issue of inherited thrombocytopenia is that I think in our ITP clinics, there will be is where we will find these patients, and I think we, all of us, probably have cases in our clinic that of patients refractory to standard therapy. We even have patients who's had splenectomies. We have a patient with MYH9 confirmed disease who had initially had a splenectomy, and there was never a review of the smear findings. So I think to think about these conditions and explore the possibility of testing for them. I think access to next generation sequencing is becoming more available, and it may become easier to test for them. And as Amar clearly showed, there may be treatment implications that some of these conditions will respond to TPO receptor agonists, or may require follow-up for hematological malignancies, or may respond to transplant. So, and as shown in that last publication, in a ITP clinic, 10 to 15% of patients will have a demonstrable gene mutation. So it's something that we should think of. I don't know if there's any other questions. I know we're a little bit over time, but if there's any burning questions, we can field it. If there's no questions, I'm going to end the session then. Thanks to both Caroline and Amar for really excellent overviews of the topic. Goodbye, everyone. See you in 2 weeks' time.
Thanks, Amara. That was we ran a little bit of time, but that's fine. I mean, I thought there's really some. I think like some of those slides, especially with the clinical stuff and just the approach, was really well presented. So